From a very sunny Middlesbrough. I'm lying, it's actually quite overcast outside, but welcome to this afternoon's webinar, which is going to be facilitated by myself and led by none other than Mr. Wong, who I shall introduce in just a moment. A real warm welcome to you all from the Royal College of Surgeons of Edinburgh, who we must thank for supporting us in this endeavour, hosting the platform to put out the webinars for your educational benefit. Now, I must just draw your attention to a couple of things that will happen in the next few minutes. Mr. Wong is going to give you some education. At some point, you will be able to answer on a poll. That will be open just for a matter of seconds, and if you could very quickly put your questions and answers down, that'd be excellent. At the bottom of your screen, you should see a Q&A button, which you can click on and ask questions, and I shall endeavour to answer those for you if Mr. Wong does not answer those already. 30 seconds about myself. I'm one of the regional surgical advisors here in Middlesbrough. But more importantly, let me introduce you to Mr. Wong. Mr. Wong, in his college photo, looks very young. He's a little bit older now, graduated from a city far down south in Bristol and then moved his way further north up to the northeast. He's an excellently skilled vascular surgeon. He is an examiner for the FRCS vascular surgery exams and the European Board of Exams, and he's done those exams himself as well and got top marks. So he's a very intelligent young man. We also have to pay a lot of respect to him as he is sits on the CQC board also for vascular surgery. So a lot of experience, and he's going to bring you 20 minutes or so on this webinar. My patient has a pulsatile lump, and how do I approach this? So I'm going to hand over to Mr. Wong now, and I'll try and answer your questions as we go along. Peng.
Right, thank you very much, Barney, and thank you very much for the very generous introduction. So welcome to everyone to the webinar this afternoon, which is kindly supported by the Royal College and the Royal and the RSA network. And we're going to talk about the case of a patient with pulsatile lump. How are we going to approach this problem? So we're going to briefly talk about what an aneurysm is, how you would diagnose it, how you would treat it, and how you would time your treatment. So we're going to quickly go through the aneurysm definition. It's an abnormal dilatation of a vessel more than 50% of its adjacent diameter. On average, the diameter of the abdominal aorta is around 2 centimeters, and abdominal aorta is considered aneurysmal if it's more than 3 centimeters. So how would you classify it if it's between 2.1 and 2.9? We call it an ectatic aorta. So this word, for those of you who loves trivia, the word aneurysms originated from the Greek word aneurysma, meaning dilatation. So a little bit of trivia for today. In terms of the epidemiology, around 1 in 25 men between the age of 65 to 74 will have the risk of abdominal aortic aneurysm. Up to 6 times more likely than women to have abdominal aortic aneurysm. The picture on the right there is that of Albert Einstein in the 1950s. When he was in his 60s, he had a ruptured AAA, not ruptured AAA, he had an aneurysm repair done none less by Nissen, famous for Nissen fundoplication. Aneurysm screening is currently therefore available now in men above the age of 65 years old. The risk factors, as in all arterial disease, smoking is the strongest risk factor, followed by conditions such as hypertension, other connective tissue disorders, such as Marfan's, lung loss, polycystic kidney disease, and also family history. Now, if you look at family history, it's important to know that if a male first-degree relative has an abdominal aortic aneurysm, the other first-degree relatives has a 12 times chance of developing abdominal aortic aneurysm as well. So it is important that if you have a patient with abdominal aortic aneurysm, don't forget to warn their first-degree male relative when they get to the age of 50 to at least have an ultrasound scan to show or disprove the presence of an abdominal aortic aneurysm. Pathophysiology, abdominal aortic aneurysm is multifactorial, and we think it is commonly due to results of breakdown of well-organized proteins of the aortic wall, such as elastin and collagen. And in the absence of elastin and collagen or decrease in their volume, then the abdominal aortic wall will destabilize and increases the risk of it dilating. The following mechanisms are considered important in abdominal aortic aneurysm development. This is combination of proteolytic breakdown of aortic wall connective tissue, inflammation and immune response, combination of biomechanical wall stress, and the interplay of molecular genetics. So all these four factors come together to cause abdominal aortic aneurysm. What are the other rarer causes? They are things like infection, and more commonly you see that with people with gram-positive organisms such as Staphylococcus. So invasion of the intima media from this infection could result in seeding of abscess and eventually weakening of the wall and aneurysmal change. You also see this quite commonly in pseudoaneurysms in certain areas where there's increased IVD use, for example. And also pseudoaneurysms differ arteriogenically from angiography, where the artery that's been punctured does not heal and become aneurysmal. These are images of aneurysms. Starting from the left, you've got a normal vessel. Then we move on to cyclic aneurysm, where there's an abnormal dilatation of part of the wall. And then you can also get fusiform aneurysm, where it's dilated overall. You can also get pseudo or false aneurysm. As we mentioned before, this is where part of the wall of the artery is weakened. The blood then leaks out from the artery, but it is contained within the extravascular connective tissue and well-contained hematoma. And this pseudoaneurysm does have a risk of rupture. We can also get dissection, even though dissection itself is not considered as aneurysm, but it can predispose to an aneurysmal change in the long term. We can also classify abdominal aortic aneurysm in relation to the renal arteries. We could call it suprarenal aneurysm when it involves the origin of one or more visceral arteries, but if it does not extend beyond the diaphragm. We call it pararenal when the renal artery arises from the aneurysmal aorta itself. We can call it juxtarenal aneurysm when the aneurysm originates just beyond the origins of the renal arteries. And in this case, there's no segment of non-aneurysmal aorta distal to the renal arteries. We also have commonly infrarenal aneurysm, which is what we normally like to see as vascular lesions, as they're probably easy to manage. And these aneurysms often originate distal to renal arteries. There's a segment of non-aneurysmal aorta that we can either stitch to, or we can either put a stent to land and seal. So typically, what sort of symptoms and signs do you get with patients with abdominal aortic aneurysm? Majority of them are asymptomatic, and most of the patients that we see are often found incidentally on clinical examination or incidentally on ultrasound or CT scan for other abdominal pathology. So symptoms and signs of abdominal aortic aneurysm depend on the complications arising from the aneurysm. Now, before this, the preceding few weeks, we talked about causes of bowel obstruction, and we can classify that into within the lumen, within the wall, and outside the lumen. And I'm going to teach you a simple way of remembering complications of aneurysms. We can classify them easily to complications arising from within the lumen itself. We can get thrombosis within the aneurysm. I've certainly seen a 9 centimeter aneurysm that's completely thrombosed. And you can see here, pictured in the top right, you have a CT scan of an abdominal aortic aneurysm, and a red arrow pointing to thrombus within the aneurysm itself. And this thrombus, in the long term, could progress and completely occlude the lumen. And similarly, if there's thrombus within the vessel, it could embolize. And with that, you can get blue toe syndrome, where the toes have patches of ischemia. And in the long term, if it's not resolved, if the arteries are all silted out, you can get ischemic limbs. Within the wall, what could we get? We can get dissection, as seen in the picture on the bottom right. The arrow is pointing to the flag of dissection. So dissection could further weaken the wall, and typically with dissection, patients will get pain. And you can also get rupture, as we know. And there's a picture in the bottom, and the arrow pointing to the extravasation of contrast out of the lumen of the abdominal aortic aneurysm. Outside the lumen, what could you do? It could compress. It could compress extrinsically on the duodenum. It can result in gastric outlet obstruction. I've certainly seen a case like that. It could compress on the ureter. It result in ureteric colic. And again, we've seen cases like that. It could also fistulate, i.e. it could form a connection with a small bowel, or what we call an aortoenteric fistula. Typically, this patient will have a small harrow bleed, a small harrow hematemesis, followed by a massive GI bleed. So again, if you don't consider this, it may be too late to plan your management. You can also have aneurysms fistulating to the IVC what we call an aortic cable fistula. If you look at the CT scan on the right, the arrow is pointing to the IVC. This is an arterial phase imaging. You normally shouldn't see contrast with an IVC, but in this case, you can see the IVC highlighted quite clearly. So blood is now gushing from the aorta straight back into the IVC, and as a result of that, there's a risk of right-sided heart failure. They're coming with shortness of breath. They may present with lower limb edema, and when you examine them, you may feel an abdominal thrill, and these patients potentially could go into renal failure. What else could it fistulate into? It could also fistulate into a left renal vein, and again, typically similar to the IVC fistula, these patients could also get right-sided heart failure. Now, abdominal aortic aneurysm is recommended to be for repair when it gets to 5.5 centimeter if these patients are suitably fit and also have predicted life expectancy of more than 2 years. If they haven't reached the size required, then we normally would say they should be optimized with antiplatelet and statin, and also optimize the other risk factors, such as hypertension and diabetes. So most of the small abdominal aortic aneurysm, by definition, anything less than 5.5 centimeter, are now normally monitored in the aneurysm surveillance clinic. And treatment is recommended if, for example, they become symptomatic, either if they develop abdominal pain or tenderness overlying the abdominal aortic aneurysm, or rapid growth. And how fast is rapid? Rapid growth is defined as any aneurysmal change more than 0.5 centimeter over 6 months or more than 1 centimeter over a year. And we know the rapid growth can increase the risk of aneurysm rupture. And this is based on Laplace law, where tension within the wall is proportional to its radius, and increasing vessel diameter can increase the risk of stress and increase the risk of perforation. The rupture risk. So as we mentioned before, based on Laplace law, on the left, as you can see, as the aortic diameter increases, the risk of rupture increases. So normally, we will consider treating when it gets between 5.5 centimeter, the risk of rupture of that untreated is between 3 to 15%, and we get more than 8 centimeter, the risk of rupture is up to 50%. So that's pretty high. So ruptured abdominal aortic aneurysm, how do they typically present? They could typically present with central, abdo, and back pain or collapse. So anyone with abdominal pain or collapse over the age of 65, especially in men, you should always consider the diagnosis of ruptured abdominal aortic aneurysm. If you don't consider it, there may be time delay and patient may not survive the hospital episode. Similarly, anyone above the age of 65, especially men with ureteric colic, you should also rule out ruptured abdominal aortic aneurysm. I will illustrate why they get that in the subsequent slides. So typically with these patients, they get a retroperitoneal hematoma, and the hematoma will extrinsically compress the ureter, typically on the left side as the aorta is more to the left and the IVC to the right, and they will then compress the ureter, and the ureter will undergo increased peristalsis to overcome the extrinsic compression, and that will then present as pain that patients often get. And often the ruptured AAA patients will have evidence of hemodynamic compromise, and on clinical examination, there'll be evidence of tenderness overlying the pulsatile expansile mass. What about the mortality? This is what we were taught traditionally. With ruptured AAA, 50% of patients don't make it to hospital. Out of those who make it to hospital, 50% of those don't make it to theatre, and out of those who survive, those who make it to theatre, 50% of them do not survive. So overall, the mortality of ruptured AAA could be as high as 80%. So let's quickly look at the case history now. How would you manage this patient? This is a 65-year-old man admitted to a surgical ward with left loin to groin pain, and the GP diagnosed left ureteric colic, which would be consistent with what he's presented with. This is a first week on call as a surgical F1. He's been called to the ward as the patient has now collapsed next to his bed. We know he has past medical history of hypertension, he's a smoker. On examination, GCS of 14, blood pressure of 96/54, heart rate of 105. So he's showing signs of shock, abdomen soft, but tender overlying the pulsatile mass. So, yeah, no prizes for guessing this. This is most likely a ruptured AAA. So we're going to do a quick poll now. This is going to be for the next 30 seconds. This will be up on your screen for the next 30 seconds. What would you do for this patient? Conservative management, central line and fluid resuscitation, large bore cannula and whole of fluid boluses, KUB to rule out ureteric stone, or wait for senior review. Okay, let's just see what everybody thinks, and then we'll get some time to think about what we will do. Okay. So let's have a look again at this case. Right, excellent. Okay, so some of you have, interestingly mentioned central line fluid resuscitation, and some of you have said large bore cannula and whole of fluid boluses. Okay, right. None of you indicated you wanted the KUB. Excellent. Let's have a quick look. Okay, now let's look at the important salient points here. The GCS 14 or 15. So this guy's conscious. So that means he's perfusing his brain. You ask him to you assess his motor function. He's obeying you and he's speaking in a coherent fashion. So he's perfusing his brain. Yes, his blood pressure is low. His heart rate is high, which may mean that he's in some degree of shock. But what would you do? Okay, so we suspect this guy has ruptured AAA. We know he's going to need some confirmatory tests and done urgently, especially a CT scan in this situation. And whilst this is ongoing, we need to consider all diagnostic investigations. But if you're worried that this patient has ruptured AAA, please, please, please get help early. Do not wait for a senior review if seniors are not available. Then, if the seniors are not available, get in touch with a vascular consultant, your friendly vascular surgeon who will advise you what to do. But time is crucial. Yeah. Now, just remember, ruptured AAA is the only scenario where ABC and fluid resuscitation are being used. The treatment for ruptured AAA is not fluid resuscitation. It is cross-clamp across the aorta or exclusion of the leak. Just imagine you have a tap that's continually leaking. You pour in more fluid, it's going to leak even more. Okay. So what you want is really turn the tap off, and the only way to do that is either cross-clamp across the aorta or exclusion of the leak by endovascular treatment. So as this patient is still conscious, apply principle of permissive hypotension, i.e. to allow minimal fluid resuscitation. The current guidelines would suggest that we should maintain the systolic blood pressure around 80 to 90 millimeter mercury. And a lot of studies on animal models have shown that in patients who are hemorrhaging, if you give them lots of fluid, and what will happen? This will increase the blood pressure, and this will increase the risk of the tamponade not functioning well to stem the bleed and increase the risk of further ongoing hemorrhage. So we've mentioned before, fluid boluses run the risk of increasing patient's blood pressure, dislodge the clot, and cause further bleed from tamponade. So what do? Do you put a central line in? Do you put two large bore cannula in? So if you look at Porter's law, the volume of flow rate is proportional to the radius and is inversely proportional to the length. So in situations like this, you do not want to put a central line. You should put two large bore cannula into antecubital fossa and hold off the fluid unless the patient is not responding to you in a conscious manner. So it's important also to assess how well perfused they are to insert a urinary catheter as a surrogate marker for perfusion. So you've seen this patient, you've inserted two large bore cannula, you put a urinary catheter in, what else are you going to do? So this is a very good, simple, systematic way of investigating any patients that you may encounter in your career. We can start with simple things like bedside tests that you can ask the nurses to do to help you. You can do a bedside test such as ECG. If you want to do a urine dipsticks in this case, ECG may show underlying ischemic changes, which may then potentially put this patient at increased risk of post-op complications, and you want to monitor that closely. You can then think about doing blood tests, venous blood tests. You can do hematological blood tests, full blood count to look for any evidence of anemia. You want to look at the platelets, full blood count. You want to look at clotting. And whilst you do clotting, be aware of the patient's medications. Are they on any antiplatelet, anticoagulation, which you may need to think about reversing? Okay, and also it's very important when you cross-match 6 units of blood ready for this patient when you get to theatre. So then we can then move on to biochemical tests such as USNEs. You want to look at the renal function, the liver function before you take this patient to theatre. If you've done venous blood gases, you want to do arterial blood gases. You want to look at the metabolic changes. if the patient is paraxial and is suspected narcotic aneurysm, then we can consider doing blood culture. Okay, and the most important thing you need to consider doing is a CT scan. A CT scan will tell us or confirm or disprove a ruptured aneurysm, and in this case, it's a large AAA, and the arrow is pointing to where the contrast is extravasating in the retroperitoneal space, as you can see there. Okay. So once you've done that, and you think this patient is suitable for surgical intervention, there are two options: either big open repair or endovascular repair. Open repair is a major procedure requiring a general anesthetic, a laparotomy, cross-clamp the aorta and iliac arteries, clamping and declamping the aorta is probably the most critical part of the operation, and perhaps the most dangerous part of the operation to the patient, because any change in hemodynamics can put increased strain on the heart. And this clamping and unclamping is the most critical part of the operation. Get open the sac, especially the lumbars, especially the tube graft or bifurcated graft, close the sac, close the abdomen. Hopefully that'll be it, but it's not as simple as that. Okay, there's the other option is endovascular repair. This is minimally invasive, but still a major procedure. It can be done under local anesthetic. This can be performed in the angio suite. Unfortunately, you've got to bear in mind that the contrast used may result in acute kidney injuries in somebody who's already depleted their blood, their body volume. This could be done percutaneously these days. And you can see the image on the right. This is a bifurcated stent graft. The aneurysm has now been completely excluded, and contrast is flowing nicely within the stents. However, even though EVAR is less invasive, less onerous, there's a ruptured aneurysm randomized control trial in the UK which showed that at 30 days and 1 year, there's no difference in survival. And most people feel that this is because of the risk of abdominal compartment syndrome in patients who had EVAR. But EVAR does confer some advantages. It's a shorter length of hospital stay, greater likelihood of being discharged home. But in the long term, EVAR does not seem to confer any extra benefits compared to open due to the risk of endo leaks. And what are endo leaks? These are flow of blood outside the stent, as seen in the CT scan here, where the arrow is pointing to contrast below the bilateral stent grafts. Post-operatively, what would you be looking out for? You may be looking out for cardiac complications such as MI, because of clamping and declamping the aorta, and also because of the loss in blood volume. They may get respiratory complications, ventilaxis, pneumonia. They could get GI complications. Typically, they go into ileus. They may get bowel ischemia because the inferior mesenteric artery is ligated, and also that in combination with vasopressors, in combination with low blood pressure, may cause typically the sigmoid colon to become ischemic. And one of the things to watch out for would be raised lactate and PR bleed on intensive care. Patients may also develop abdominal compartment syndrome due to edema within the bowel. These patients may also go into renal failure. They may go into limb ischemia. They may go on to develop limb ischemia or compartment syndrome. So you need to watch out for this. And just remember, in all these patients, because they have evidence of atherosclerosis, please do not use TET stockings unless they have pedal pulses. Palliation: if we're going to offer patient surgery, we've got to balance the risk against the benefits, and that need to be discussed with patient and family where possible. Patients with terminal prognosis from underlying malignancy or poor premorbid condition may not be suitable candidate, because these patients may not survive the hospital episode, or they may not survive long enough to get back to where they are. A majority of patients with poor premorbid conditions may end up long-term in nursing home, and this may be something that the patient or the relatives may not wish to accept. Patients needing CPR prior to surgery are unlikely to survive the hospital episode. So if they are needing cardiopulmonary resuscitation, we will normally say these patients are very unlikely to survive because they must have had a catastrophic bleed. Okay, let's moving on now from abdominal aortic aneurysm. We're just going to briefly talk about other aneurysms. We talked about pseudoaneurysms before. Commonly you see that in IVDUs and also following catheter-directed angiography. On the left, there's a picture of an IVDU with the arrow pointing to the pseudoaneurysm. And typically these patients have been injected into the vein. The vein is now thrombosed. And you can see picture in the middle here, the right leg is markedly swollen due to DVT. and they then accidentally inject into the arteries, you then extravasate and cause a pseudoaneurysm. Popliteal aneurysms, these are the second most common aneurysms that we encounter. Up to 25% of abdominal aortic aneurysms are popliteal artery aneurysms. So if you see somebody with abdominal aortic aneurysms, please don't forget to examine their popliteal arteries. We normally treat them when they get to more than 2 centimeters, or if there is evidence of laminated thrombus. This could be either repair with an open bypass graft or a stent. So the picture on the bottom left, the arrows are pointing to the aneurysm, and the picture of the patient's right leg is a picture of a graft. And on the right, you've got an aneurysm here and a stent graft across it. So don't forget abdominal aortic aneurysm, don't forget to examine the popliteal artery. Iliofemoral aneurysms, the current guideline for treatment would be when aneurysms of iliac arteries get to more than 3.5 centimeters. And we can see the CT scan here with arrows pointing to both iliac artery aneurysms, to one on the right measuring 7.3 centimeters. So in summary, be aware of ruptured abdominal aortic aneurysm mimicking other abdominal pathology. High index of suspicion is crucial. Get help early from your friendly vascular surgeons if you're stuck, and apply principles of permissive hypertension. Please do not over-resuscitate these patients because the consequences may be more dire. Thank you.
Thank you very much, Mr. Wong. That was really good. Now, there have been about 50 questions already coming in, and I've been furiously trying to answer as many as I possibly can. To those whose questions I did answer, I hope you are happy with those. I thought, Peng, we could just keep a couple to one side and get you to answer a couple of those, if that's all right. Unfortunately, people keep asking questions, so the ones I had at the top of my list have disappeared. But one question just on the epidemiology, could you suggest why men are more likely to get this than women, an aneurysm that is?
Yeah, so I think if you look at aneurysms, it's an interplay of lots of different factors. So perhaps most of the men are smokers, or high risk of high incidence of smoking amongst men, and men have high incidence of hypertension, diabetes, for example. Yeah. And also, as we mentioned before, there's a genetic interplay amongst all this. That's something that we haven't really fully understood. Yeah. But I think it's a combination of all the factors.
Okay, that's great. Thank you very much. And then there was another specific question that was asking about signs and symptoms of dissection as opposed to rupture. So, I mean, I'll try and give an answer to that one. I think, you know, we shouldn't confuse what's going on, and your history is really an important part of that process. Now, we always make generalizations and then say you should never make generalizations, but in general, somebody who presents with an aortic dissection doesn't already have an aneurysm. Usually this is a normal caliber aorta, and that patient is often hypertensive, and then they've had a flow dynamic change that's stripped through an atherosclerotic plaque or something like that to cause a dissection flap. You then get terrible searing pain of almost like a tearing sensation. And because more often than not, this is in the thoracic aorta, patients would describe that as, you know, in between the shoulder blades type of pain. And the other differentiation that could help alongside the symptoms and the hypertension would be any evidence of any end organ dysfunction. So if it were to strip out, for example, one of the iliac vessels, then you would lose the pulses down that side. Now, you have, on the other hand, a ruptured aneurysm, where yes, they will get pain, but classically it's a loin to groin pain. It's lower in the abdomen. And usually that patient, you know, presents on that spectrum of dying or just about to be dead, or, you know, just drops dead at home. So there is pain in both. There is cardiovascular instability in both, but there's definitely hypotension in one and definitely hypertension in another. Another quick question, Mr. Wong, why or what is a mycotic aneurysm, and how does it come, or how does it form? Can you just give us a very short answer on that one? Right.
A mycotic aneurysm is an infection from somewhere else that's seeded into the vessel wall, and then the bacteria could then sit within the intima, the media, to form abscess formation, and as a result, there's weakening the vessel wall, and then the aneurysm developed. So typically all these patients will not have an aneurysm prior to the presentation. They will then suddenly present with this abdominal pain, and the CT scan will show aneurysm with surrounding fat stranding. There may be some changes around the vessel to suggest that there's an infection going on.
Okay, last two questions, and then I'd like you to have one final say, if that's okay, Peng. There's been a lot of questions about the use of ultrasound in the diagnosis of aneurysms. Just to be clear, an ultrasound scan is an excellent screening tool, and it's fundamentally important in the screening program, which Mr. Wong mentioned. It is not any use and shouldn't be relied upon to make the diagnosis of a rupture. I think in a history context of collapse and abdominal pain, with a fast scan that shows a large aneurysm, that's going to give you a diagnosis, but it doesn't tell you the important information of at what level in relation to the renal arteries is that aneurysm, is it surgically repairable or not? The other question, Peng, just for you to answer, because a lot of people have asked this, why are TED stockings bad in these patients? Please, could you answer that question for us?
Right, okay, very quickly. Most of the abdominal aortic aneurysm patients will have atherosclerosis. So the atherosclerosis is not just limited to the abdominal aorta, so they may have atherosclerosis in the lower limbs. And if these patients have peripheral arterial disease and they put TED stockings on, they're not getting enough blood down to their leg. If you put TED stockings on, that's going to restrict further blood down to the limbs. And we certainly see year on year, 1 or 2 patients needing amputation as a result of incorrectly application of TED stockings. So just be aware.
Could you just give us a one-sentence synopsis, Peng, of what you think is the most important thing to take away from this?
Okay, history is very important. History, clinical suspicion, and time. All three must come together. If you don't suspect it based on the history, you don't move quickly, you don't diagnose quickly and treat quickly, then you may not have a patient at the end of the day.
Okay, thank you. Now, we've come to the end of our time. Just a couple of things to say. First of all, thank you all for tuning in. Thanks for your questions and thanks for paying attention. We're going to flash up in a second the title of the next webinar on Thursday, which is Aids to Manage